Hello everyone and welcome. Let's jump right into today's high-yield MCQ discussion explainer. We are focusing strictly on obstetrics and gynecology today. If you're a dedicated learner looking to really pressure test your clinical reasoning, well, you are in the perfect place. We're going to break down these concepts logically, directly from our core materials.
So in this explainer, we're going to tackle 5 absolutely crucial, highly testable questions. I'll be explaining exactly what the reason is behind every correct option and, just as importantly, why the other options are totally incorrect. By the end of this session, these concepts will be completely cemented in your memory. Okay, let's dive right into it.
Moving straight to MCQ number 1, take a look at this scenario. We have a 53-year-old postmenopausal woman who is found to have endometrial hyperplasia with atypia. The crucial question here is, what is your immediate next step in management? Are we looking at progesterone, a hysterectomy, a Mirena coil, or dilatation and curettage? Think about it for a second.
Right, so the correct answer here is option B, hysterectomy. What's really absolutely crucial to understand here is the clear distinction between these pathologies. You see, the presence of atypia carries a massive 8 to 30% chance of turning into a malignancy. Because of this high risk, in a postmenopausal patient, conservative medical options like oral progesterone or a Mirena coil are completely out of the question. They just aren't safe enough when the malignancy risk is that high.
This is a heavily tested topic, so let us review the exact algorithm. When you encounter endometrial hyperplasia without atypia, the malignancy risk drops to just 1 to 3%. For those patients, the best management is progesterone, specifically the Mirena intrauterine system. But, just like in our patient's case, when hyperplasia presents with atypia, the gold standard is always a total abdominal hysterectomy, or a simple hysterectomy. And of course, this is often preceded by hysteroscopy and fractional curettage to properly assess the cavity first.
Let's see how this builds our diagnostic knowledge with MCQ number 2. So, what is the minimum endometrial thickness on a transvaginal ultrasound above which you simply must perform a biopsy in a case of postmenopausal bleeding? Is it 3, 4, 7, or 9 millimeters?
The correct answer is option B, 4 millimeters. Look, in cases of postmenopausal bleeding, your very first step is always a TVS. If that TVS shows an endometrial thickness greater than or equal to 4 millimeters, it mandates an immediate endometrial biopsy. Therefore, 3 millimeters is too low, and waiting for 7 or 9 millimeters? No way, that would dangerously delay the diagnosis of a potential endometrial cancer.
To permanently cement this clinical pearl in your head, let's look at the complete pathway. A female presents with postmenopausal bleeding. Your first step? A TVS. If the thickness is less than 4 millimeters, we can safely be conservative and just give tranexamic acid. But here is the catch. If the bleeding persists despite that, or if your initial measurement is 4 millimeters or higher, you absolutely must proceed to an endometrial biopsy or hysteroscopy with fractional curettage. Don't forget that.
Moving swiftly to MCQ number 3. We have a 50-year-old perimenopausal woman presenting with abnormal uterine bleeding, or AUB, for 2 months. What should be our immediate next line of management? An LNG IUCD, progesterone-only pills for 3 months, a hysterectomy, or endometrial sampling?
The correct choice here is option D, endometrial sampling. Here is the absolute golden rule. In a perimenopausal female over 40 years of age in India, you cannot just start medical management blindly. You must definitively rule out malignancy first. Jumping straight to an IUCD, pills, or a major surgery like a hysterectomy without that tissue diagnosis, that is a very dangerous misstep.
Let us quickly summarize the high-yield rules for endometrial biopsies because examiners just love this. In reproductive age females, you biopsy if the thickness is over 11 millimeters or if the bleeding just won't stop. For perimenopausal females over 40 in India or 45 globally, you biopsy regardless of the ultrasound findings, literally no exceptions. And as we just learned, for postmenopausal females, that hard cutoff is 4 millimeters.
Excellent. Now, let us tackle MCQ number 4. This is a very classic clinical scenario featuring a 55-year-old lady presenting with a third-degree uterine prolapse. Which of the following is the best management for her? Fothergill repair, sling operation, vaginal hysterectomy with pelvic floor repair, or the Chirocard procedure?
Option C, vaginal hysterectomy with pelvic floor repair, is your correct answer. The entire rationale here completely hinges on her age and parity. She is a 55-year-old menopausal woman. Option A, the Fothergill or Manchester repair, is strictly reserved for reproductive age women who want to keep their uterus. And option B, the sling operation, that is exclusively for nulliparous women or those planning future pregnancies.
Let's lock in these surgical indications right now. Your choice of prolapse surgery depends entirely on age and parity. Sling surgeries? Think nulliparous. Fothergill? Think reproductive age. And vaginal hysterectomy is the absolute gold standard for third-degree prolapse in menopausal females. Oh, and here's a bonus high-yield point. If this menopausal patient also had a cystocele and rectocele, the specific name of that surgery would be Ward-Mayo's hysterectomy. That includes anterior colporrhaphy and posterior colpoperineorrhaphy. Keep that in mind.
Finally, here is MCQ number 5. We have a highly recognizable 9-box grid. Which female genital pathology is this specific tool used to evaluate? Is it prolapse, vulva cancer, carcinoma cervix, or endometriosis? Notice the specific variables plotted here, like AA, BA, C, and D.
Option A, prolapse, is undeniably correct. This brilliantly illustrates the pelvic organ prolapse quantification system, or what we call the POP-Q grid. It's an objective measurement tool exclusively designed for staging pelvic organ prolapse. It is totally irrelevant for staging vulval cancer, cervical carcinoma, or endometriosis. Those rely on surgical and clinical staging systems that are completely separate from this grid.
To truly master this concept, you need to know exactly how the grid functions clinically. The POPQ system uses the hymen as a fixed reference point to map 9 specific sites: anterior points, posterior points, the cervix, the genital hiatus, the perineal body, and total vaginal length. But here is the most critical takeaway. All of these measurements, except for total vaginal length, must be recorded while the patient performs a Valsalva maneuver to capture the absolute maximum extent of the prolapse.
All right, before we wrap up, let's quickly lock in today's 5 high-yield takeaways. Number 1, always perform a hysterectomy for endometrial hyperplasia with atypia due to the high malignancy risk. 2, memorize that 4 mm TVS cutoff for a postmenopausal bleeding biopsy. 3, always sample the endometrium first in AUB patients over 40 years of age in India. 4, choose vaginal hysterectomy for third-degree prolapse in menopause. And 5, the 9-point POP grid is your gold standard for prolapse staging.
I really hope this structured breakdown has sharpened your clinical reasoning today. But before you go, I want you to think about this. We know the protocol for a postmenopausal woman with a 4 mm endometrial thickness. But how does your management change if that exact same patient is currently taking tamoxifen for breast cancer? Think about it. For more such high-yield MCQ discussion explainers, do follow our channel, The Learning Me. Do like, share, and subscribe, and I will see you in the next explainer.